really nervous, man.
Let's do this, team, just like
All
we
right.
usually.
We are live. Obviously, you can tell we're already having fun. So welcome, everybody. You're going to have fun with me and Fritz and Clint at this webinar today to talk about how direct primary care creates cost savings for employers. So we're really excited to be talking about this topic because employer-sponsored direct primary care has been growing in popularity just like a hockey stick in the past several years. And one of the biggest questions that employers and brokers have is, what is the financial impact of direct primary care? So I'm so excited to be here today with two of the preeminent thinkers and experts on this topic to help learn more, impart their knowledge, and just kind of share and obviously have fun as we talk about this. So Fritz, do you want to start and give us an introduction about who you are?
Indeed. Thank you. Yes, I am Fritz Busch. I'm a principal and consulting actuary for Milliman. I've been involved with the DPC movement for about 10 years now in various capacities, mostly hanging out with doctors who are always very gracious to welcome an actuary to their conventions. So I definitely appreciate that. But we have been, involved with the DPC movement mainly in helping to prove out and support the value proposition. So we do have a study out there that was done about 5 years ago now. We're working on a second study, but that study is available if anybody wants the link. It's a Society of Actuaries study that has been used for the last 5 years. But that's basically how we are involved, is really looking at the cost savings and trying to frame up a solid articulate value proposition for DPC.
Wonderful. Clint, tell people who you are.
Thanks so much, Beth, and awesome to join you and Hint as well as Fritz here today. I'm a physician out here in Colorado, and I'm the founder and chief medical officer of Nextera Healthcare. We were the first DPC in Colorado here over, this is our 16th year. So like many of us early pioneers, we had been doing fee-for-service, insurance-based primary care and said, gosh, we need to do things better, and created a model where we could do primary care and the way it should be done, and also run our private independent primary care practices. So as the CMO, I do a lot of executive administrative things for Nextera Healthcare, our company. And then I have a full panel of DPC patients that I take care of as well out here in Colorado. So that's a little bit about what we do and myself, and happy to get into more detail here soon.
Wonderful. Well, thanks for those intros. In case anyone doesn't know me, I'm Beth. I'm the head of Hint Connect here at Hint Health, and I help connect businesses with direct primary care, essentially. So today, during this webinar, first we're going to talk a little bit about what direct primary care is and how it's been growing in the employer-sponsored space for those of you attendees that might be new to the concept. And then Fritz is going to lay the data down on us and tell us what Milliman has been studying for the past several years, and in kind of the mechanisms and the expectations for cost savings for employers with DPC. Clint is going to tell us some patient stories and how it works on the ground, what he's seen with the many employers that he supports in through Nextera. And then, hopefully we can talk a little bit about, if we have time at the end, how brokers can maximize DPC cost savings and answer some of your questions. So if you do have questions for us throughout the webinar, please put them up in the comments. If we can't get to them during this webinar, we'll answer them on LinkedIn afterward. So I'm going to share a slide now. Haley, if you could help me share the first slide about what direct primary care is. I can't describe direct primary care with Clint Flanagan in the room, so I'm going to let him do it since this is their Sweet 16 with DPC. So Clint, can you help the newbies understand what DPC is?
Yeah, for those of you new to the concept or to the word direct primary care, I guess my first question is, where have you been? I sure would hope by now, especially if you're a benefits advisor, consultant, broker, and or a physician, that you've heard of, hey, what is direct primary care? So So simply, DPC, I think it's important for all to know that it was founded by physicians that had been working in insurance-based primary care. So all of us back in the day that were doing this one way or another, we said, hey, we can't continue to do this because this is fee-for-service insurance stuff because it's really challenging and it significantly impacts the doctor-patient relationship. So it's a model of care, so primary care, where patients or their employer pay a pretty affordable monthly fee for unlimited primary care. And then we use a lot of technology to help, let's say, enable or foster that doctor-patient relationship. And so, yeah, at its simplest, it's a monthly fee for primary care. And there's way more detail there, and I appreciate putting this slide together. We like to compare it to the status quo, or what people are currently doing with their Blue Cross, Cigna, or Anthem or Blues plan, and how they're getting primary care in a fee-for-service chassis. So many of us docs, we don't think patients should be transactions. And in that fee-for-service model that probably many of us are familiar with or have worked in, patients are transactions, and that model is based on volume. And so DPC is not based on volume of patients that you see per day. So it really helps foster and or even restore the doctor-patient relationship, number one. Number two, it allows for independent primary care practices to stay independent, where you've got the doctor or clinicians owning the clinic. And then number three, there are tons of benefits that we're going to get into. But part of that is, hopefully we can help move the dial on the overall health of our patients, doing proactive preventative care, which is obviously right within the wheelhouse of primary care physicians and clinicians, number one. But number two, along the way, really be a good steward of our patient's pocketbook. So that is something that, every day primary care physicians are writing orders. And when you have appropriate plan design and nice setup on that front, we can really be an excellent steward of the patient's pocketbook as well as the employer's pocketbook. So I guess the last thing I just would say there is it's arguably, now that we're in our 16th year and DPC is in every state in this country, it's arguably one of the best ways to get primary care in the U.S.
Yeah, agreed. Thank you for that explanation. I think that's great and extremely concise given how exciting and complicated DPC can be. I want to talk a little bit about the growth in employer-sponsored direct primary care. For those of you who aren't familiar with Hint, we are a DPC technology company first and foremost. We've been in the market for over 11 years. We support over 1 million patients, thousands of clinicians on our platform. And so we have great insight into what's happening with employers working with DPCs. And so I pulled some recent data on what we're seeing in terms of growth trends. And without sharing exact numbers, over the past 6 to 7 years, we've seen the number of employers grow from the hundreds to the high thousands implementing DPC, including, in terms of membership, over half of DPC membership is employer sponsored. The average annual growth rate, if you average it over the years, is 59%. So it continues to grow, and we've seen it actually grow at a faster pace in the last couple of years. So we're really excited to see these trends. Like Clint said, if you haven't heard of DPC, where have you been? But it is really, we work in this space. We talk about it every day. We're enmeshed in it. For most people, this is a newer concept. They might not have the idea of the reach it has, especially being outside of a market like Colorado, where that's so DPC heavy. So this is really popular. It is taking hold. Employers are really interested in this and continue to implement it as a benefit for their employees. And we see over 1,500 clinicians just who work with Hint who are supporting employer-sponsored membership. So we continue to see these numbers grow. And as these numbers grow, we want to answer the question for employers: what impact is this going to have on your finances? Because employers are the fiduciaries of the healthcare dollars for their group, and they want to do right by both their business and for their members. And so I'm going to hand it over to Fritz to kind of walk us through what his research has looked like and what his findings have been in terms of how DPC impacts a health plan.
Awesome. Thank you. And my screen is up, right? Everybody can see that? Is that operating correctly?
It looks great, Fritz. Yeah.
Okay. Great, thank you. And I have to caveat, I recently recovered from this worldwide funk that's been going around, and so I'm fine now, other than I have a cough, and it's pretty incessant. So if I go on mute to cough, I appreciate your patience up front. Clint, if I had a DPC doctor, I'd be over it already. Right, there's the best pitch I can make, right, for DPC.
We can maybe help you out there, Fritz.
Yeah, thanks, I appreciate that. So yeah, so I'll do about 10 minutes here on out of maybe a 25-minute presentation that I did earlier this year, which is up on the screen here. The title of it was, what does value look like? And the sort of the genesis for the title of that anyway was, oh, let me move my screen here. Hang on. Technical difficulty. There we go. The genesis for the title of it anyway was a quick 10-second anecdote. When I was a young parent, we took a parenting class, and the leader of the class said, well, look, when you're teaching your children character virtues, you can't just say, well, Johnny, be kind, or Susie, you have to share, right? Because kids need to see what that looks like in action. The words mean nothing to them, right? So they very tactile. They have to see it. They have to see what it looks like. And as I thought about that, I thought, value means different things in different contexts. And DPC being relatively new. I mean, Clint's in his 16th year, but again, in terms of its expanse, in terms of going mainstream, it's still relatively new. And so I think the idea here was, let's try to get as specific as possible on what exactly drives DPC value, and try to put some numbers to it, right? Get some magnitude so you can help understand where are these savings coming from. So very quickly, I don't want to read a caveat slide to you. That's really boring and really lame. But I do want to point out that I do have some numbers in here. These numbers are good for illustrative purposes. Please don't go out and build a 10-year pro forma off of any numbers that I that I present today. Okay, these are representative. They're educational, but they are very reasonable numbers to make the points that we want to make today. So that's really it on that. So let's start very quickly by talking about what is value. Just generically, everybody learned this in college. It's quality divided by cost. And so I want to take each of these pieces, look at them, and then we'll kind of stack them up, and we'll compare it to a typical DPC fee, and then we'll see where we land. All right. So that's kind of a roadmap here for what we're going to do. So first thing is, we want to talk about the cost piece. What do we mean by net cost? Well, actually, what don't we mean by net cost is, if you shop for a car in this manner, I feel sorry for you, right? Just looking at the sticker price is not the way we shop for most things, right? We have a slightly more nuanced calculation process mentally, because we know, using this example, that the sticker price here is not telling the whole story. There is some net cost. There's future downstream cash flows that are going to change this value proposition, right? It's probably going to look something like this, right? The price up front was $15,000, but you got a ton of repairs. Turns out that the net cash flow here was actually in favor of I guess that's a Ford Explorer there. So obviously, unless you are in the market for a 72 earth tone LeSabre, or whatever that is, this is not going to be a very smart decision if you don't consider all of the cash flows that are coming in. I don't have a slide for this too, but obviously there is a qualitative difference between these cars, with most people preferring agreeing that the car on the right is probably a higher quality car. So these are kind of the two aspects that we want to look at when it comes to DPC, the cost and the quality aspect. So let's get started with the lower net cost. So when we think about the DPC fee, right, and we're going to stack this up here in just a minute to kind of show you, how these things compare. But this is where the savings are going to come from. Okay, I'm going to give you 3-4 different buckets here, and then we'll put some numbers to them and see where we land. But the first bucket is what's on the screen here, is what we call diverted claims. Okay, this is very simple. These are just simply the claims that under a DPC arrangement, you're paying for all of your office-based, anything that goes on under the office and is covered under that fee is no longer going to show up in your fee-for-service claims feed. So if you are a self-funded employer, you're going to pay your claims as they come about. These claims now, these are like your E&M codes, your 99 codes, venipunctures, all this, and Clint can add probably a plethora of other services that would fall underneath this banner. All of these claims now that used to be filed fee for service are no longer going to appear in your claim feed for anybody that uses a DPC doctor. So this is very simple math. It's just that those claims evaporate because you're paying the fee in its place. The second source is avoided claims. All right, so these are the claims that are no longer going to show up directly because of the model itself. All right, so under DPC, Clint mentioned this in his slides. You know, you have unprecedented access to your provider, whether it's the doctor or whether it's the physician extender. You have same-day appointments most of the time, or next-day appointments. There's no wait times, longer visits. There's a lot of benefits here that come from simply having access to your DPC provider. And what that is going to do, it's going to manifest itself almost immediately, maybe not day one, but certainly over time as the model gets some teeth and employees learn to use their DPC doc. This is going to reduce emergency department visits, urgent care visits for sure. This is a finding that we found on our first DPC study, was statistically credible, showed a 50% reduction in emergency department visits. And this makes sense. This is very intuitive because people will not have to go to the emergency department if they can go to their doctor and have immediate access to that. Specialist visits, we're working on the data for that. Our first study, we did not have the detail to really back up the idea that there's less specialist visits. But I will say, based on the DPC doctors that I've talked to, this is a very intuitive result, because if I ask a DPC doc, hey, under DPC, especially the doctors who have fee-for-service experience, you know, if I ask them, do you have a broader scope of practice than you would otherwise under fee-for-service? They almost all universally answer, insofar as they feel qualified to do it, absolutely, they have a broader scope of practice. So, you know, instead of referring something out to the dermatologist or whoever, they often will try to keep that in-house, manage that condition right there. Again, insofar as they are qualified to do so. So these are reductions in claims that you'll see as a direct result of the DPC model. Third one, Clint already mentioned this as well. This is health improvement. So this is longer term. You'll notice that these sources of savings are kind of durationally organized here, right? The diverted claims are immediate. The avoided claims are, you know, within the first year, year and a half, something like that. And then health improvement, a little bit more long term, right? Where you're starting to have some of your preventative measures and these types of things really take hold on a population. But health improvement, you know, is really just managing a population so that there's fewer conditions, actually healing people, right? And clearing up their conditions. The conditions that the chronic conditions that remain, excuse me, you know, are managed better. You have fewer acute exacerbations, which can result in overnight hospital stays or referrals to specialists and things like that. So this is actually the model, the DPC model that Clint talked about before, actually taking hold in a population over time and actually improving that population, their health, and as a result, the utilization of unnecessary services and ultimately costs go down. Last one is, I'll put it in here, is reduced spend. Many employers who have DPC, in fact, it really only makes sense in this context, are self-insured, and they're probably paying a TPA to do some of their utilization management. Now, if I were an employer in this space, the first thing that I would do is I would say, well, look, I have a DPC arrangement, and these providers are very willing and capable to do some of this utilization management themselves. That's what I hired them for. And it actually makes a lot of sense for them to do that as the primary care, the quarterback, right? So there should be an opportunity to go and reduce some of your administrative spend with your TPA. So let's take these four, stack them up, and see where we land. I've chosen an $85 fee, illustrative. This seems to be a reasonable mark. Some are higher than practices are higher than this. Some are lower, but we're going to choose 85. That was not chosen by convenience, by the way. I think that's a reasonable number. And let's go ahead and drop in these sources of savings here and see how they stack up. So you can see the diverted claims is worth about $40 PMPM. Avoided services about 25, and then the reduced UM is, depending on what someone could possibly negotiate on that. It's relatively small, but I wanted to make sure this was complete. So this is for an average employer. The immediate and the short-term savings, is, and again, don't get too hung up on the exact numbers. You can see that that's about 80% of the fee is accounted for, right, almost immediately. And remember that this does not include, so this gap of about $17, and this does not include that component that is very difficult to quantify right now, which is that health improvement piece. We know it's pretty intuitive that that piece is positive and could be material, but we don't have that in there because we don't have a study yet that really hones in on that piece of it. All right, so let's talk very quickly about the higher quality. Clint mentioned this as well, but when we talk about a DPC as a product, what are the quality components now of the value equation? Well, the first one is increased primary care utilization. So it's well known in the insurance world that if you put a financial barrier in front of a service, you're going to get less of it. Conversely, if you take that barrier away, you're going to get more of it. Well, with DPC, there's typically, I don't know of a situation that this is not the case. There's no copays when you go to your primary care DPC physician. And that is going to increase your primary care utilization. And that's a good thing. That's precisely what you want, is you want people going to your direct primary care. You're paying for it. And so more visits to the primary care. I suppose there's a limit on this, Clint. I suppose you don't want to see somebody 15 times a month. Maybe not, right? He's shaking his head the other way. But all of that increased utilization is no additional cost to the employer. Only good can come from that, right? So that's value proposition number one, or quality proposition number one. Number two is related to that. There is a member cost sharing benefit. Clint mentioned managing the patient's pocketbook. Well, it's zero out of pocket, and the DPC physician can do so much more as well to reduce the downstream out-of-pocket costs of your employees. A last one is just, excuse me, just generalized, just a better product. So again, Clint had a slide on this. Same day appointments, longer visits, no wait times, very high NPS scores. Everything I've ever seen is well above 95, 98, enormously popular with employees. This is going to increase productivity, lower absenteeism, et cetera, et cetera. So all of these are qualitative features of just simply you're paying a fee, but you're getting a superior product relative to fee for service. All right, so let's go back, and this is where we left off. So we had about on an average employer, does not include health improvement. We had $68. We had about a $17 gap. If I add in my qualitative components, skip all the math that I did behind the scenes, you can see that we've more or less, we have a reasonable path here, a very intuitive path to covering an $85 fee, right? So this is essentially a break-even proposition at this point. But keep in mind what we do not have in here. We don't have that health improvement because we don't right now have enough data to do a quantitative study on that. And then we haven't quantified any of the generalized product quality features, right? So you're at a break even at a minimum. And we haven't really even included these things. So that's a pretty strong, value proposition, particularly when you haven't included some pretty significant things in there that are not quantifiable necessarily. All right, so what happens, like I said, this was an average. So what happens when you have a lower cost employer? So this could be an employer that has all 26-year-old engineers that run triathlons, right? They're just not as sick as the normal population. They have fewer conditions. Obviously, in a case like that, you are going to have, everything is going to be lower because they just simply don't have, they don't have as many places. Well, there's no conditions, essentially, is what it is, right? There's nothing. So most of the value proposition in a situation like this is going to be, as Clint mentioned, on the preventative side, where you can establish a relationship over time and really work on the preventative side of health improvement. But this is an example where, mileage is going to vary on DPC by group and over time, right? So you might have 1 year where, your fee easily covers all of the claims, and another years where it won't. But over time, right, these are averages. So it's important to note here again that mileage does vary for a number of different reasons. Obviously, you know where this is going. If I have a high cost employer who has a lot of conditions in his employees, right, the value of DPC becomes a slam dunk, right? The amount of savings that you have is going to easily exceed the fee. So the value proposition there is pretty strong. Which is ironic, right? But it makes sense when you think about it. When you have an effective tool to reduce costs and to manage care, where is it going to be the most effective? Well, it's going to be in populations like this that have the highest need. Okay, last slide I want to talk about real quick, because I think I'm a little bit over time here, is this idea of duration with an employer and employee cost. So you can see the black line is healthcare cost by age. You can see everybody knows this. They tend to go up. Us older people, we tend to get more conditions and have more health needs. It's pretty well known. The duration with the employer, though, is really interesting, because, as I said before, the populations that need good quality primary care the most, at least immediately, are these I don't know if you can see my mouse, but it's in this area where your healthcare costs are starting to go up around age 45. You'll also notice that that's about the time people start to stay with their employer longer. And this is kind of a perfect storm for a DPC arrangement, right? Because what this means is when people need the care the most as they start aging, they have a tendency to stay with an employer longer. And with a DPC arrangement, that just gives more time for the model to take effect, and for the physicians and the caregivers to establish those relationships and really let the teeth of the model sink in, and reduce the cost over time. So I'm going to stop there, and I'm sure that hopefully that provided some discussion fodder here, but I'll turn it back over to Beth.
Thank you so much for that, Fritz. I saw you present that at the HINT Summit last year, and I was blown away. And then I'm so glad this audience is able to see it. I had a question for you, especially because you mentioned DPCs being, or Clint mentioned DPCs being independent physicians. And there was a recent study that came out, I believe about 1.5 years ago, from Harvard, that said that with more health system consolidation, physician acquisition by large health systems, the cost for everything for employers goes up. Is that something that you would look at, given that DPCs are independent, as part of the cost savings of DPC?
Yeah, I can give a perspective on that, but ironically, it's probably not going to be a very actuarial perspective on it. I think DPCs are competing in a true market-driven environment, right? These are independent doctors who are offering a product. My presentation is really geared around the fact that they are selling a product, and they are competing on a value proposition. So my thought there is, that doesn't really exist in the rest of the healthcare ecosphere. Whereas it does in DPC. DPCs, I would imagine, your slide was a very good one and showed the growth of DPC. There are still places, I looked at the DPC mapper the other day, places that don't have a DPC doctor, but there's a lot of places where DPC doctors are now actually competing with each other, right? So they're in the same space, they're going for the same employers, right? So my feeling on that is that is going to only benefit the DPC movement, as that actually helps to hold prices down and improve the product quality that they're providing. So that's a little bit different answer than maybe what you were going for, but that's the first thought that came to mind.
Yeah, thanks for that. Okay, Clint, I'll turn it over to you now to share where the rubber meets the road. What are you seeing in your patient population and the employers that you support, in terms of kind of real patient stories or real outcomes on the ground, from either your own patient panel or the clinicians that are part of Nextera? You're on mute.
Appreciate that question, Beth.
Yeah.
Sorry about that. My wife probably wishes she had a mute button for me, but I would say what I'm going to talk about here is not unique to Nextera. I would say it's a commonality across direct primary cares in the country. So every day that you have physicians and healthcare teams taking care of patients in direct primary care clinics, there are interactions that happen, right? 5 to 10 interactions, give or take, versus 25 interactions like we used to do as fee-for-service doctors. So patients are coming in, and again, many of us do a ton of lifestyle medicine, very much a proactive, preventative approach of saying, what can we do to partner with you to help you get healthier and reach optimal health, whether you're 25 or whether you're 65. And so as you drill down to that, let's say a patient comes in and they otherwise think they're pretty healthy, and you do some preventative screening labs, and turns out they have an elevated hemoglobin A1C, and so you found diabetes in that patient. And to Fritz's point, that patient may be feeling great, but when you find diabetes early like that, and say in a 30-year-old, boy, it sure obviously helps that patient right then and there. But over time, there's less spend for the patient as you think about disease states that aren't found and the challenges that happen down the road. And there's definitely less spend for the employer. And so you get that patient on metformin. Perhaps that's metformin, for example, that you have in your office that you get for pennies, and the patient picks it up right there. Or perhaps you're working in understanding the patient plan, and maybe the patient has a high deductible health plan, and they could potentially run that through their deductible health plan. But let's say Optum is their PBM, and running it through a middleman like that may very well cost the patient a lot more money. And you can use an entity, whether it's Cost Plus Pharmacy or GoodRx or your own in-house pharmacy, and get that medication for a few dollars versus more. So the medication is a lane. So anytime we're writing orders, there's a cost associated. There's obviously a price and a cost. And a lot of us DPCers make it our business to know those things. You can apply that to labs. So discounted labs, you can get a cholesterol check for less than $7 with direct primary care doctors, because we have relationships with LabCorp and Quest where it's direct pay relationships. You can take that to imaging. So let's say you need an MRI. You have a deductible plan. You have a $5,000 or $10,000 deductible. We could potentially run it through your Cigna plan, but running it through your Cigna plan, while it'll be applied to the deductible, you're going to be paying a different rate for your MRI because it's a Cigna contracted rate at the imaging facility versus the $400 to $500 that you would pay directly to the imaging facility. So this navigation that I'm talking about, this precise care navigation when we're writing orders, happens every day. So we're uncovering disease state quicker, number one. Number two, we're creating a plan that helps get patients to a better, healthier place. And number three, we're doing that while also saying, hey, if you've got a PPO plan with your work with United, if you have a deductible plan with Cigna, if you have a health share for coverage, because again, almost all DPC members, obviously they're getting direct primary care for all their primary care and urgent care needs, but the high majority of them have some type of coverage plan. And so we want to be sensitive as physicians and healthcare teams to what kind of plan do you have and how can we best utilize that or not utilize that coverage plan to get you the right care, right time, right place, right cost. And these stories happen every single day. Our doctor friends that are still in fee-for-service insurance-based models, working for big health systems, working for Optum, working for Village, they're in a different lane here because they're seeing 20 to 30 patients a day, and they are at an arm's length. They're at a distance from that coverage plan. They might not know the nuances, and or even if they do, they might not have the time. And again, it's not that they're bad doctors and healthcare teams. It's just that they're so busy with a patient panel of 3,000 patients, seeing 30 patients a day, that they, have no clue what kind of coverage that you have. And it's that model that we're competing against, and we will win every time on that type of model.
Yeah, Clint, can you tell us a little bit about how Nextera or other DPCs typically engage patients? Because I think that's a really important differentiator between a fee-for-service model where, if an employer-sponsored member wants primary care, it's up to them to find a physician directory and then go through that directory and call until they find someone who can take them, then wait the amount of time that they need to see the doctor, which I think the statistics on average say it's a couple months, but in practice, I think a lot of people experience it several months to get established as a new patient when they even find a doctor who's taking a PCP who's taking new patients. Can you contrast that with what new patient onboarding looks like at Nextera? Because I think, to Fritz's point, you need to have people engaged to see those savings. So what does DPC do to engage patients?
Way more than the existing fee-for-service, insurance-based primary care and coverage plans that most employers today still have. So realize that I believe the last time I looked, for 2024, single coverage for a employee is around $9,000 in premiums a year. Number one. Average premium for family coverage, this is per Kaiser, KFF, is around $25,600 in premium. So Fritz was talking about value. So realize that that's the amount of money going out of the employee and or the employer's pocket. More of that has been shifted to the employee to pay for a premium. So that's what they're paying for, right? And they have a broker that shows up at open enrollment, talks about the plan. You get your 30 or 40 page health benefit book, and there's no physicians, there aren't any nurses that are at those open enrollment meetings. And then January 1, let's say coverage starts, you go into your United or your Cigna packet. You may even have a bolted on care navigator as part of the plan, like Rightway or some of these entities that bolt on that you have to pay more money for to try to find yourself a clinician. And yet in the community you're in, Kansas City, Arlington, Virginia, Denver, Colorado, through that traditional process I just described, it takes 2 to 3 to 4 months. We just opened up clinics in Arlington, Virginia, 4 to 6 months to try to find a primary care clinician. So you find that clinician, right? That's the status quo. And then you come in with your visit, and then maybe that doctor or clinician has a 10-minute slot for you. So you're paying all that money, right? $9,000 or $25,000 for a premium, and yet you can't find a primary care physician. And then once you find them, that physician's on a fee-for-service chassis where you're a transaction and you have to pay a copay, or God forbid, after your annual physical, you've now got to pay the full bill for that care. So you're self-funding your own care, and the visit's $200 to $300. So I think it's important to get down a little bit of the fine detail there so you understand that's what most Americans are still doing. Contrast that with direct primary care. So we just did this for a couple of employers. An example of this is one employer out in Kansas City had around 80 open enrollment meetings. Our medical team and admin team attended all of those. So we had nurses, doctors at those meetings. We had an awesome benefits advisor team. We described to this large employer, 4,000 lives, hey, here's the benefit plan that you get starting January 1. And oh, by the way, your employer is paying the direct primary care fee. And then we asked the crowd, how many of you have ever had a doctor show up at open enrollment before? No one. No one, right? So they're buying something in the old model. They don't know what they're getting, but they're buying it, and no doctors, no nurses show up. So that's one way that direct primary care is different, is we actually show up at open enrollment meetings to talk to employees about the benefit plan that they now have, one. And then two, we like to continually show up even year in and year out, even after the employer is on, because there's always new things that are coming up. And then we have a whole engagement team. So what happens as an employee is you get an email from our team in December saying, hey, listen, your company now has Nextera. We'd love for you to get engaged with doctors. Here are the 5 doctors that are in your area. Who would you like to see in January? Then our team, A, we send an email out, B, we call you, and then we help you navigate to that physician that is available not 3 months down the road. That physician's available this week. And you can get in, and rather than see that doctor once or twice a year, like your old model you're spending $25,000 for, typically we have way more engagement, 5 to 6 to 7 to 8 times more engagement. And it's not the, hey, come in for your once a year physical. It's like, hey, think of us like a gym. And the more we see you and connect with you face to face, virtually, et cetera, hopefully the better we get to know you, the better the relationship is. And that'll develop a level of trust and relationship that is nearly almost non-existent in existing fee-for-service programs.
Yeah, thank you. That's incredibly helpful, and I think that's a differentiation that businesses who have implemented DPC know about, and businesses that haven't can't even conceptualize yet. I do want to ask you one more question about kind of the on the ground experience, which is after hours care, because Fritz mentioned that the diversion, especially from the ER, people tend to go to ER nights and weekends. Um, in fee for service, in insurance based care, many primary care, many pediatric clinics do have an after hours line. You're typically connected with a nurse or someone who kind of nurse level or a little bit below, and they're usually triaging. They're usually saying, go to the ER or call again tomorrow for an appointment. But the experience with DPC is fundamentally different. It's a true treating and diagnosing kind of in that after hours space to be able to avoid, the same thing Fritz said, to avoid that care at really, really high cost settings that both is expensive for the employee and the employer, and a horrible experience as a patient. So can you tell us a little bit about what after hours care looks like at Nextera?
Yeah, so a common thread in DPC practices across the US is, typically, let's say we're open Monday through Friday, 8 to 5. But we realize that urgent care and emergent issues don't always happen between 8 and 5. And so as part of our model, and this is not unique to Nextera, after 5 p.m., you, the patient, can connect with a physician about your urgent need. So 50 to 70% of urgent care visits are they're circumstances that can be taken care of virtually. So a lot of us DPC doctors have systems set up to help with that. Back in the day, I just would give my patients my cell phone, but we now have a pretty cool app called Spruce Health that allows us to really connect with patients, video visit if we need to, fill out a template on sinusitis and send it our way. And so now you're actually talking to the doctors that you know and trust after 5 p.m. for yourself or for your kid that has a fever. And then maybe that doctor's like, son of a gun, I am concerned about your kiddo. Let's see that kiddo tomorrow in clinic. And you get in and have a visit that day with a doctor and the healthcare team that you know and trust. That does not exist in that expensive fee-for-service primary care that I talked about. And as a result, you've seen the explosion of urgent cares in America. If primary care worked well, we wouldn't have urgent cares. Primary care is not working well, so you have urgent cares peppered all over the place. And then, God forbid, patients, rather than go to an urgent care, they'll go to an ER. I spent about 15 years in the emergency room as a physician. That's part of why we created Nextera, is because half of those visits in the ER are not emergencies. Patients come in, we triage them, we discharge them, they feel better, and then a month or two later, they get a bill for $5,000 to $10,000. Now they feel worse again, right? Then they have to pay that for years. And so we obviously in direct primary care realized these barriers and challenges, and we said, hey, we want to be available to our patients not only Monday through Friday, 8 to 5. We want to be available after 5. And as we look at the data at Nextera, 25% of the touches that we have on our Spruce telemedicine engagement platform happen after 5 p.m. So you can think about that, just extrapolate. The majority of those things would probably be urgent care visits or potentially even ER visits. So to Fritz's point, that is a whole bucket of claims that we are decreasing, but even better yet, it's just better care, right? Yeah. You shouldn't have to use Teladoc on your plan and pay an extra PMPM for Teladoc or Amwell or any of these entities because you can't get in to see your primary care doctor. So if your broker is bolting that stuff onto your Cigna plan on a fee-for-service chassis, he or she is failing you as an employer, right? There are benefits advisors out there that realize you have a fiduciary responsibility as an employer with your employees' money, similar to the 401k fiduciary. And you need to be connecting with benefits advisors that can help on this front. Some of these people are found at like Health Rosetta. So not your status quo, big WTW, a locked in or so broker that's rinsing and repeating your expensive plan and being paid a percentage of their comp is based upon your premium. And so if it's increasing, again, lackluster plan, no urgent care after hours, and you're paying a ton of money for it, then your broker's getting paid on the back end. So yes, there are ways to do better. And interestingly, they can be ways where actually you can save money versus spending more.
Yeah, I mean, it just makes sense with the way that we all live our lives. Most of us are working 9 to 5 or longer than that. And, our kids are in school or in daycare until then. And get to the end of the day and that's when the time you have to figure out what's going on with yourself. So I think all the DPCs that work with Hint Connect, pretty much every DPC that I've ever met has that true after hours care. And it's such a huge value for both patients and for employers. And I think the point that you made, that DPCs are open to see people next day, is a critical component of how the model works. Your schedule is not full for 6 months with 17 visits kind of slammed in day to day, with absolutely no flexibility for the way that people actually experience their health or sickness. So,
one quick point I forgot, Beth, and I've just recently became aware of the data on this. While we know that more and more urgent cares are staffed with NPs or PAs, and again, they can do a great job, nurse practitioners or PAs in an urgent care setting, what we're seeing is a number of emergency rooms, standalone ERs, are being staffed without an emergency medicine physician in the ER. So you have a PA or an NP in that ER. And that's data that's come to light here in the last number of months. So again, as a guy that did ER for 15 years, that had great teams and great PAs and NPs that I worked with, I just want you all to be aware that, if you're walking through those doors and it is a full-on emergency, my gosh, I'd sure hope that I have a emergency medicine physician taking care of me, right? Versus not that. And part of that is because you have these health systems that are realizing that it doesn't cost as much to employ a PA or an NP, so they're hiring them in place of. And so I just want to call that out. Again, as you have a really good relationship with your direct primary care physician, there should be way less utilization of urgent cares and ERs.
Beth, one thing I wanted to add in, go back to something Clint said a little bit ago about the engagement. And when you asked the question about what does it look like when an employer engages with say Nextera? And whenever I hear the term engagement, I always think about this was a study that was done like probably 10 years ago now, at least. It was in Health Affairs. And they did a study to measure, well, what is the effect on cost of patient engagement? And they had various measures for what constituted an engaged patient versus a non-engaged patient. And the number that came out of the study, I always remember it, was they said, well, engaged patients are 8% less costly, right? So that was the big takeaway. But what that study did not do, and that I think is so important, and Clint's example of this just brings this out, is what is the value of an engaged provider? Right? I can't even imagine, if I go to my doctor and they're not engaged with me and they're just behind that screen and they're tapping away and I got about 10 minutes with them, that does not signal engagement to me. And I can't, it's hard for me to conceive a situation where a patient is less engaged when their physician is already that engaged. So I just think that's so important when it comes to health improvement and these longer term cost savings that right now are not as quantifiable, is how this patient and physician engagement actually work together. So yeah, I love that example, Clint. That's just a great example of the difference and just a great physical example of what does engagement mean, right? Is they are there getting to know the people. So.
On the topic of engagement, I want to pull up one more slide just to kind of talk about the ways Clint mentioned brokers, and especially brokers who are willing to get creative with plans and do things differently for employers to really create value for employers. And I think member engagement is one that has come up, member engagement, how do you get people to go see the PCP, has come up for a long time, but it assumes a functioning primary care system, which we don't always have. So in terms of how, and Clint, I'd love to hear your ideas and thoughts here too. But in terms of different ways that brokers can help optimize the savings for their employers beyond what Fritz may have talked about, are one, incentives for engagement, making sure people understand when they sign up for DPC, like This is not passive. You go in, establish the relationship. This is a long-term relationship with your PCP, and whether it's a carrot or a stick, making sure people are getting in for that first visit within the first 30, 90 days of the plan. Another way that brokers can and employers can optimize the savings through DPC is kind of going back to what Clint talked about, which is direct independent providers in the community outside of direct primary care. And a lot of people may not even realize this exists, especially if they're in marketplaces that have really dominant health systems. But pretty much in every community now, there are independent surgery centers, independent lab centers, independent imaging centers that are, their value prop is high quality, low cost care. And the rates that they offer both to employers and cash pay can be literally a fraction, 20%, 30% of what insurance negotiates to pay for those things at large hospitals where you're really paying high facility fees, high name brand tags. So DPCs can optimize care going to those places and actually help employers find those resources in the community because they're so entrenched in that environment. And then finally, network coordination. We touched on DPCs being independent a little bit. And I know when I worked in health insurance, it's so hard to offer a narrower network. People expect such a broad network, whether they're getting the value from it or not. But because DPCs are independent, they're not tied to one health system, they can take patients and help steer them toward lower cost options in the community, whether that's through a narrow or tiered network, an open access or reference-based pricing plan, centers of excellence, or more of those direct pay vendors. So, there's a lot of exciting ways that DPC can help optimize the rest of the plan that are part and parcel of what DPCs do every day. So I know we're coming up on time. I know we have a question for Fritz about when the next DPC white paper is going to be in. I've heard people ask you this 100 times, so I'm curious to know if we're going to get a firm answer today on it.
Yeah, so it's a great question, and so our last study is now coming up on 5 years old. So we really are anxious to refresh it. We have a data bank that we're working with now, so we've done that, and so we're looking at this year. We were shooting for first quarter, to have the draft done, but we're probably a little bit behind that schedule now. But it is forthcoming. It'll be 2025. And we're excited about it. So it'll be a bigger study than what we did before, a few more lives to look at, and we'll have a lot more details in terms of what's driving the savings and things like that. So yeah, so stay tuned for that.
Great, we love to hear that. Just to put in a plug for that effort, Fritz, are you still looking for more data from DPCs and self-insured employers to add to the study?
We are always looking for more data. There is never too much data that we could have. And so, yes, if anybody that is listening, or of anybody that has an employer arrangement where the employer would be willing to share that downstream data from their TPA and from their pharmacy vendor, we can get you set up pretty quickly in terms of secure data transfer, HIPAA agreements, and things like that. So this is kind of a rinse and repeat for us. So we can make it pretty easy if anybody is willing to put some DPC data forward there.
Great, wonderful. Well, I don't see any more questions in the chat, so I'll leave it there. But I just want to thank both of you for your time, your expertise, your passion for the topic. It definitely came through. So I think this is going to be a great asset to share with employers and brokers who really want to understand the ins and outs of DPC cost savings, and hopefully is an entree to more data that we'll get this year as well. Fritz is out. All right, thanks, Clint.
Fritz is leaving it to me. Really appreciate the opportunity here, Beth and Hint team, and love having Fritz on to talk about this. You brought up the study. the second study, we're participating in that. And let's just say at a high level, I highly anticipate it's going to be even more robust and have some great conclusions compared to the first study, which had some good conclusions. I would also just say, especially for the brokers that are out there and or benefits advisors, where is the most recent study on employers that have fee-for-service insurance-based primary care? And what do those conclusions show? Are they saving employers money? Are employees getting better care? And is that fee-for-service insurance-based model working? To your point, Beth, about ambulatory surgery centers and trying to really keep healthcare local, keep the dollar local, and have that referral go to your board-certified orthopedic surgeon in town that owns his own ambulatory surgery center with his partners, versus having that elective procedure go to a system. In general, as we talk to our employer groups and our doctors across our over 300 locations now, nothing should be sent to a health system unless it's like an ICU stay or it is to be inpatient. If it's an elective procedure, hysterectomy, gallbladder removal, hernia, all of that should ideally be sent to physicians that own their own practices and own their own ambulatory surgery centers. Even better yet, we've got really innovative plan design that allows, for example, a school district we take care of here in Boulder area, those employees, when we write for an elective procedure to Nextera Surgery Center or to Smith Medical in Denver, that employee, the teacher, the principal, the bus driver, can get that elective procedure for $0 out of pocket. So imagine an ACL repair for $0, a colonoscopy for $0, a hysterectomy for $0. So when you have better plan design and you get rid of that super expensive facility fee that happens at the big health systems, and again, no disrespect to the doctors or nurses, it's more so that facility fee, that is can be a tremendous downstream savings to the employer group. Plus, I'll just tell you from a medical standpoint, I would much rather have my elective procedure done by the anesthesiologist, the scrub team, and the surgeon that have a bundled rate in that ASC nearby than go to a health system where they have high turnover in their surgical teams, their scrub teams as well as anesthesia, in that kind of fine detail that us doctors know about. So again, kind of drilling down a little bit to that plan design and specifics. And at the end of the day, it goes back to right care, right time, right place, and DPC physicians and healthcare teams are super well equipped and have the time to help care navigate for those patients. Now that I've said that, we do as much as we can at Nextera to keep people away from surgeons, away from health systems, and really focus on, lifestyle, sleep, nutrition, exercise, and emotional health, because we have the time to do so. So that's the majority of our day. But every once in a while, you're mountain biking and something happens.
Yeah, well, when you're in a position where you need a surgery, it's never good for the patient. So the more affordable and better and less likely to kind of create a denial that we can make it for people when they do have to leave the walls of primary care is great. So we'll leave it at that. Thank you so much, Clint. I think there's plenty of more topics we'd like to cover. So maybe we'll do another one of these on another topic sometime soon.
Yeah, appreciate your time, Beth, and thanks for all that you and Hint do.
Okay.